And welcome back to our third and final installment of discussions of pharmacokinetics, how drugs are handled by the body. So, we've talked already about how drugs are absorbed in various routes of administration. We've also talked about different factors affecting drug distribution. We're now going to talk about how drug action is terminated. That is how your drug dose might be eliminated, and eventually then, obviously, you would no longer be under the influence of that drug. So there are various routes of elimination. Obviously, everything that goes in has got to come back out. And there are various routes by which drugs are eliminated. And the first of these is, of course, through the kidneys, excreted in urine. One problem with this particular route is lipid-soluble drugs are usually reabsorbed, so they have to be transformed into other metabolites. And so this is one of the things that can make metabolic half-life so much longer is this process takes some time. So water-soluble drugs are obviously going to go right out with the rest of the water. But lipid-soluble drugs are usually reabsorbed, and so they're transformed into other inactive metabolites that can be excreted or are water-soluble. Some drugs are eliminated through the lungs, so typically only what we call volatile or gaseous agents. So things like alcohol or inhaled anesthetics can be eliminated this way. This is one of the reasons why you smell alcohol in people's breath. It's not because of the fact that they drank the alcohol through their mouth, but it's actually the fact that it's being eliminated through the blood vessels in the lungs. And so you're actually breathing out alcohol. So that's one way. Some of these very few drugs can end up being eliminated. Through the bile or intestines, some drugs can be eliminated in this way. They are often, however, reabsorbed throughout the rest of the digestive tract. And finally, some drugs can be eliminated via sweat. And in fact, again, this is another way in which alcohol is sometimes eliminated. I think you probably all know someone who you can smell the fact that they are eliminating alcohol. So these are the four general routes of elimination. Tends to be through the kidneys. This is the reason why urine analysis is usually used to test for illicit drugs. So that's how they're eliminated. But in order for them to be eliminated, oftentimes they have to be metabolized or undergo what we call biotransformation. That is, they have to be transformed into something else or metabolized into something else. You've all probably, or most of you, I would hope, have taken some sort of biology and remember the Krebs cycle through which ATP is metabolized out of other constituent substances. So basic definition of biotransformation are chemical changes that usually reduce the effect of drugs and increase their excretion, so this is how they're metabolized. Our kidneys are used to filter waste from our blood and collect it in the bladder and then eliminate it. And so most of these drugs will be chemically altered and excreted through the kidneys, and this is usually accomplished again by the liver. Lipid-soluble drugs are harder for the kidneys to hold on to. After collection, the molecules tend to cross back into circulation before they're excreted. So they usually tend to be biotransformed before they're eliminated. Because what's happened is they get into the kidneys, then they get absorbed back out of the kidneys, and they get back in, et cetera, et cetera. This is why those drugs tend to have longer metabolic half-lives. So that's the way drugs are metabolized and then eliminated. The process of metabolism tends to occur in the liver, and the liver is an important part of the body that protects the body from toxic substances. In fact, it detoxifies most of what we consume. It contains enzyme systems that can detoxify those harmful substances. Changes from highly lipid-soluble to less lipid-soluble, so drugs that are highly lipid-soluble or fat-soluble will be metabolized into less lipid-soluble substances by the liver and thereby can be eliminated through the kidneys. They're often likely to ionize some of these particular substances, which again alters their elimination ability. And finally, they may produce another lipid-soluble molecule, which might be an active metabolite. So for example, we talked about this previously. Cocaine, in conjunction with alpha alcohol, creates what's called cocaethylene, which is an active metabolite, which is reabsorbed and then has a longer half-life and has a more potent effect on the brain. And so it's important to understand whether or not an active metabolite might be part of the process by which a drug is being processed by the body. So how does the liver handle these drugs? Well, there are substances that transform drugs, which are called enzymes, which are just different kinds of proteins that break down and different substances into other components so that they can be eliminated. Most are non-specific. That is, they will go after most any substance if that's a particular enzyme that will work for that. These are referred to as the microsomal enzymes. The main category of these particular enzymes are called the cytochromes, the cytochrome P450 families. The details of this are less important to me. You will have to know what cytochrome P450 is and be able to name it because it's such an important part of how drugs are handled. The cytochrome P450s are physically located in what are called the hepatocytes or liver cells. So you want to certainly have a general understanding of this process. So these microsomal enzymes are a critical part of how drugs are broken down and ultimately eliminated from the body. Now, there are two major phases of drug metabolism, the first of which is phase 1, the second of which is phase 2. Phase 1 is usually cytochrome P450 CYP, which is just one of the subtypes of the cytochrome P450s. Again, they're most concentrated in the liver. They do occur in other places, but they're mostly in the liver. There are about 12 cytochrome P families. CYP 1, 2, and 3 are the most common for drug metabolism. We talked already about 3A and 3A4, which might be affected by grapefruit, and they tend to metabolize over 50% of drugs. So this particular subset is particularly important for metabolizing out most of the drugs that we might consume. There are a variety of factors that influence the cytochrome P450 family enzyme activities. Any disease, particularly any disease that might affect the liver, hepatitis, cirrhosis of the liver, which is caused by chronic alcohol abuse, any of those are going to affect the cytochrome P450 families. And as a result, anyone with any kind of liver dysfunction is going to metabolize drugs very differently from the rest of the population, usually much more slowly, and will have much longer metabolic half-life. So it's an important consideration. Obviously, your species, we're all people, so we're mostly concerned with that. It's important, though, when we talk about development of new drugs, that each species is different. We have to look at species that have the right enzymes for eliminating the kinds of drugs we're talking about. It's the reason why some drugs are toxic for dogs, for example, but not humans. Ibuprofen, can't give that to your dog. We can take it just fine. Dogs can take aspirin, but not ibuprofen. So it's important to understand how these drugs affect the liver. We're going to talk a little bit about acetaminophen, which is Tylenol. Tylenol is particularly toxic to the liver. So if you're looking for a good hangover cure, I don't recommend acetaminophen. Age is another very important factor in how these enzymes work. Children are not just smaller people. There sort of is this belief out there that you can just adjust a drug dosage down based on the size of the child, and that's not true. Children are very different. In fact, I think most parents would agree they're almost another species, but that's another argument for another day. But keep in mind that younger adults, children, are not just smaller adults. Older adults certainly have very different drug metabolism rates, and it depends on the type of drug. If it's a drug they've been taking a long time, but the general rule of thumb is they'll metabolize drugs more slowly, and they will require lower doses because of that. Important to keep in mind. Genetics is another important component. In fact, there is emerging evidence that there are specific genotypes that metabolize drugs very differently. I read a recent paper examining how individuals with red hair who have a specific genotype because they have red hair actually metabolize drugs much more rapidly. And in fact, there had always been a lore in anesthesiologists that individuals with genuine red hair require much more anesthesia. And in fact, that is borne out to be true in a variety of studies that show those individuals are very efficient at eliminating some drugs. So genetics is an important part of this. Environment is always important, of course. Stress, diet, amount of exercise an individual gets, all of these are important in how these enzymes might function. So what happens is sometimes our recent experiences will affect the enzyme systems, and this is what we call enzyme induction. That is, those recent experiences can alter the way enzymes function and whether or not they function at all. In fact, there are also is also evidence that past experience with a drug will alter the way enzymes work. So this is one of the reasons why people will develop tolerance to some drugs, because they will become so efficient at producing the enzymes to metabolize those drugs. And in fact, this is somewhat of a learned behavior. There is evidence that, for example, people who abuse heroin will start to produce more of these enzymes if they're shown visual cues associated with drug abuse. You know, a needle or the drug itself will actually cause their body to increase production of those enzymes because it expects the drug to be presented. So again, this is called enzyme induction. When we have past experience with drugs, affects those enzyme systems. And so this is part of the process by which people oftentimes have to use more and more of an abused drug because they've actually gotten more efficient at eliminating it. There are also interactions across drugs that we want to think about. So for example, St. John's wort, which has an active ingredient, stimulates a specific receptor in the liver, which induces the CYP3A family, which breaks down many other drugs, like theophylline, warfarin, which is used for anti-clotting, some birth control pills, and some immunosuppressants like cyclosporin, which are given to patients who are undergoing some type of organ transplant. So oftentimes doctors will ask you about what drugs you take, and people will forget about these kinds of over-the-counter supplements they're taking because they don't think that they're drugs. But it's important to understand that they can have an effect on how other drugs are broken down. And so if you're taking St. John's wort, it might actually be reducing the effectiveness of something like birth control pills. So it's something to keep in mind. You probably want to always ask your doctor or pharmacist before you take one of these over-the-counter supplements. Enzyme inhibition occurs because some drugs will inhibit cytochrome P enzymes and increase their own levels, as well as levels of any other drug metabolized by that enzyme. So what that can do is produce toxicities. So if we're talking about inhibiting an enzyme that breaks down a different drug, that causes a drug interaction. And that's one of the reasons why you want to be very careful with drug interactions. Later in the semester, we're going to talk about inhibition of antipsychotic medication by selective serotonin reuptake inhibitors, which are antidepressants. So taking these drugs in combination with one another can actually cause one to make the other one not work. So we want to be very careful about that. We'll also talk a little bit about selective serotonin reuptake inhibitors and how they inhibit metabolism of painkillers. So if you are an individual who takes an antidepressant, you have to make sure that your doctor knows that, because they will have to give you a different kind of pain medication. Very important to keep in mind. So, a variety of enzyme inhibition studies we've talked about recently. Studies have shown that grapefruit levels can induce a several-fold increase in levels of particular drugs that can result in augmented therapeutic or toxic effects. And by augmented therapeutic effects, I mean they're packing a bigger wallop. So if we're talking about a drug like Ativan, which is lorazepam, you're probably going to get a great deal of sedation if it's taken in conjunction with grapefruit juice, or if you've been drinking grapefruit juice recently. The magnitude and the mechanisms of this interaction appear to be the result of a significant inhibition of gut wall cytochrome P450 isoenzymes and something called P-glycoprotein. So food-drug interactions is really a particular clinical importance. Grapefruit and grapefruit juice is consumed by approximately 21% of households. So again, understanding how drugs and food interact with one another are particularly important. So just to take a look at this overview of that, we have an oral dose, we have the gut wall and one of the cytochrome P's in first-pass metabolism, which then results in portal circulation, off the liver, and off the blood circulation. Grapefruit juice actually can have an inhibitory effect here, so keep that in mind. Also keep in mind that there are genetic effects of some of these enzymes. 20 to 30 million subjects have no cytochrome P2D6, so they metabolize drugs slowly. High drug levels will result from ordinary dosage. High risk for adverse drug reactions. We'll get no response from certain prodrugs like codeine, because codeine has to be metabolized into morphine. Whereas there are also 15 to 20 million subjects who have CYP2D6 gene duplications, which result in rapid drug metabolism and no drug response at ordinary dosage, which we call non-responders. So it's really important to understand everybody's going to react a little bit differently based on their experience and based on their genetics. So very important to understand that process. So sometimes drugs are actually not metabolized, but are actually excreted intact. This is kind of the exception, not the rule. But there are some, like lithium, which is used to treat bipolar disorder. Shrooms, in large doses, can be toxic and lethal. Small amounts are, of course, hallucinogenic. The hallucinogenic ingredients are not greatly metabolized and are passed to the urine. And some people have discovered this and recycled the drug by drinking their urine. I can tell you that this class of drug users oftentimes will do the same thing. Methamphetamine is, in fact, released intact, and the urine of methamphetamine users will contain bioavailable and active methamphetamine. So, important to keep in mind. We talked already a little bit about excretion. Primarily it's accomplished by the kidneys. Kidneys are there to keep the right balance of water and salt in the body. They filter everything out of the blood and selectively absorb what might be required for us to have. It's important to understand that the pH of your urine can be manipulated to alter excretion of drugs. And in fact, if you have altered the pH of your urine through some sort of dietary change, you might have some issues with drug alteration. So this can be very useful for eliminating certain drugs in an overdose. I suspect this is probably the way in which people try to flush out their systems for passing drug tests. I'm not really sure. I haven't really looked at that in any great detail. But excretion is an important part of that. And we're going to talk more about drug testing later. Okay. Finally, I want to talk a little bit about rates of elimination. And to me, this is one of the most important parts of understanding how drugs function. And understanding drug dosage effects, it's really critical to having good insight into appropriately taking medications. If you know the half-life of a drug, you know if you can miss a dose or if you need to be right on with a dose. So for example, I take a medication that has a half-life of 50 hours. So if I take a pill on Tuesday night, it takes until later Thursday night, so 50 hours later, for half of that to be eliminated. So skipping Wednesday is probably not a big deal. Now, for a drug that has an elimination half-life of 4 hours, if it's something you want a constant amount in your blood, like, say, an antibiotic, and then you need to be taking that drug very regularly, which is why drugs like antibiotics often have to be administered with very regular schedules. So this is the rate of excretion for most drugs, and it's described in terms of a half-life. Alcohol is the exception to the rule. The general rule for alcohol is 1 drink an hour. So if you have 10 drinks, an hour later you'll have the alcohol of 9 drinks. Whereas with a half-life, you're going to eliminate half every period of time, whatever the half-life of the drug is. You probably should be familiar with half-lives from chemistry, but basically it's just the time taken for the body to eliminate half of a given blood level of a drug. So why is this so important? Well, oftentimes we want people to maintain what we call steady state, because we want the amount of drug circulating in their blood to be at what we call a therapeutic window. And we want it to stay there. And so understanding how quickly the drug is eliminated allows us to understand how often to give them a dose and how long it's going to take for them to reach that steady state system. And in general, the rule of thumb is 5.5 to 6 half-lives. So if a drug has a 24-hour half-life, it's going to be 5.5 to 6 days to reach that steady state. So it's an important thing to understand when you're trying to decide whether or not a drug has been effective. It might be that you haven't reached that appropriate therapeutic window. So when we talk about understanding this process, we talk about what's called a first-order system. For most drugs, the amount of drug metabolized is proportional to the amount of drug present. So it's fairly straightforward. You have 1,000 milligrams, one half-life later, it'll be 500 milligrams. Another half-life later, it's 250 milligrams. Relatively straightforward. So a certain enzyme can break down 50% of the amount of an administered drug in 30 minutes. If 100 units of a drug are present, then 50 are metabolized every 30 minutes. If 1,000 units are present, then 500 are metabolized every 30 minutes. And so this is not a linear effect. This is actually a decay rate function. So the system is designed to get rid of the same proportion of drug in a given time period. And again, alcohol is the exception to this rule. So to give you an idea, you can give a dose of chlorpromazine. It's going to be absorbed and then eliminated over a particular amount of time. And so most patients will have some sort of clinical response in the 200 to 900 milligram dose range. So obviously we want to try to maintain a dose somewhere in that range in order to keep the schizophrenia symptoms at bay. So we want to reach what's called steady state. And this is that point of balance at which the rate of drug administration approximates the rate of excretion. Because what we want to do is we want to keep patients in that therapeutic window. We don't want them getting don't want them above it because that's toxic, and we don't want them below that because then they'll be symptomatic, and we don't want that. So to just give you an idea what this looks like, if we start at time 0, and then we just go out the number of half-lives, and so if one half-life is 24 hours, then time 1 would be 24 hours later. If the half-life is 10 hours, then time 1 would be 10 hours later. So that's how you read this. So if we give someone a dose, obviously it's going to take a little while to reach what we call peak plasma concentration. That dose is going to start to roll off. One half-life after it's been absorbed, half of it will be gone, okay? And then another half, and then another half, and another half. So this is dose number 1. But what we're going to do, so this is time 0, and then at one half-life later, we introduce another dose. We're going to add this dose to that dose and end up here. And then that starts to drop off. We're going to introduce another dose, and then that starts to drop off. We'll introduce another dose, etc. And then eventually we'll get to the point where we're eliminating as much as we're taking in. And again, it's called steady state concentration, and it's proportional to the dosage interval. And you'll notice it's right here at about 5.5 half-lives. And so what we have then is the drug is peaking and dropping off within our therapeutic window. And this is an important consideration for any drug that you might be taking, is how long does it take to reach steady state. So we have dose of 100 milligrams at 0. At time 0, we don't have any cumulative drug. By the next dosage, we're going to eliminate half. So by the next dose, we still have half of the first one. So now we're going to be at 150, right? Let's say it's 100 milligrams. So now we have 150 milligrams because we're adding another 100. So by next dose, it's 75. Then our next dose, our cumulative drug at dosage time is 75, and then it's 87.5 and 93.7, and eventually we're right there close to 100. So look at some examples. This is important. I'll probably post some more examples just in a worksheet of some kind, so you can take a look at how this is effective. It's an important part of understanding drug dosing. Again, these are right out of your textbook, so take a look at some of these figures as you look at different kinds of doses across half-life. So this is dose 1, dose 2, dose 3, concentrations of the drug reaching steady state. So, again, our goal here is to reach what's called the therapeutic window. And so for medical treatment, it's important that the right amount of drug is maintained in the blood. If the amount is too high, the therapeutic effect will not be any better, and there might be undesirable side effects. If the amount is too low, then we won't have any beneficial effects. So something like an antibiotic, what that might mean is the person will develop a resistant type of bacteria to that antibiotic. So the drug should be given in such a way that the blood concentration stays between a level that's too high and too low. And again, this is called the therapeutic window. We want it right at that point where it's effective, and we want it to stay there for the period of time that they're on the drug. Okay, so that's the end of our introduction to pharmacokinetics. As we start talking about different types of drugs, this will start to become a little bit more clear, but these basic processes you really need to have a good understanding of because we'll be talking about how they affect our understanding of how drugs work and why they might be abused differently. So for example, the elimination half-life of cocaine is around 45 minutes, whereas the elimination half-life of methamphetamine is 10 to 12 hours. And so many people have found that they like methamphetamine better because they don't have to take it as often. So it's an important consideration when we start talking about how drugs are effective. All right, well, next time we will pick up on pharmacodynamics and how drugs actually have their effect in the brain.